So at this time we have a staff which is exclusive to the clinic, myself as the only prescriber so far. We are working on mentoring and training more physicians and residents. Then we have addiction counselor, a registered psych nurse, and LPN who's working only in the clinic. So we've expanded from half day to 2 days. However, we still have lots and lots of resource constraints, time constraints on my part, and space constraints, as you just noticed in the clinic today. The message that I would want to say, and I've already said, is more and more authorities need to recognize if patients have to be treated in the best possible way for chronic pain, we need to have more resources. When we talk of physiotherapy, then the barriers are it costs the patient. When we talk of self-management, more of mind-related therapies like cognitive behavioral therapy, counseling, they're all going to cost a patient. So these are chronic pain patients, which constitute about 30% of patients that come to any primary healthcare office. These patients, when they are advised other therapies, they don't have the money, or they have other barriers like transportation, mobility barriers. They can't access those services. And yet giving and prescribing a drug is so easy because it's covered. So we have to get our priorities right, and I think that's the message I want to say. If we have to get our patients off of opioids, we have to offer them alternative non-drug therapies. That needs to be covered. We have to train more and more of our fraternity, that is the medical providers, in understanding, because I think there is a myth out there that chronic pain is helped by opioids. It is not the case. And already I see a lot of push towards awareness in this. There is now a trend towards decreasing the opioid prescriptions. Our regulatory authorities are becoming more and more aware and conscious of that. There are more conferences, more educational activities in which we can participate as providers to understand more about how to manage chronic pain in a rational, evidence-based manner rather than prescription of opioids. Because all of the world is not managing chronic pain like this. This is mainly a North America crisis. A lot of our authorities are recognizing this, and there is a reduction in the duration of opioid prescriptions. So typically a doctor now is prescribing for shorter times, and that actually promotes more healthy interaction between doctor and patient, because a patient is going to come again and again if you're giving small duration drugs. And so and like I said, lots of educational opportunities and lots of literature now is coming to us which says how little benefit there is of chronic use of opioids in non-cancer pain. I'm not talking about cancer pain. Opioids definitely have a use in cancer pain.